Good evening, gentlemen, ladies, dignitaries, friends. I'm sorry, I'm going to paint a very bleak picture of the Indian population starting from UK and globally in terms of healthcare. In London and UK, we see a distinct divide in population. One is white European population, and the other is a population from Indian subcontinent. And I'm sorry to say that what we see is frightening. Population of the Indian subcontinent is very sick, ill, with premature vascular disease in terms of heart attacks, strokes, renal failure. It's all related to risk factors or genetics, or I'll come back later on that, maybe unexplained causes. If I travel from central London on the tube, or you call it metro here, from the tube station called Westminster, to the east of the city, what we see, the traveling east from Westminster, each tube stop represents nearly 1 year of life expectancy loss. And the reason for that, as you move from Westminster to east of London, you go into a predominantly Indian population. That explains the mortality of the Indian population.
Sir, sorry to interrupt. I'll give you another mic.
Okay. All right. We just put it here.
Sure. Thank you. Sorry, sir.
That's right, don't worry. The average life expectancy of male Indian GP in UK is about 58 years. And I'm talking of an Indian doctor there. Unfortunately, more than 2/3 of MI and half of CVA are younger than 55 years of age. I'm talking of Indian population. And 70% of these have hypertension and diabetes. MI is 6 times more likely in diabetics, and actually 6 times more likely in Indian population as compared to European population. Therefore, diabetes and hypertension probably are the largest preventable risk factors for MI and CVA. If I compare the population, Indian population with American and UK population, it becomes very clear that Indian population is selected for some premature problems. The average age for a person from Indian subcontinent is about 52 years to have an MI or stroke, as compared to US, which is 65 and above, and UK is 75 and above. Recently, I think 2 years ago, the American College of Cardiology established a very important ongoing study called Pinnacle Study. And it's an epidemiological study about the risk factors and MI in India. And it tells the same story which we already know. It tells also the same story which Salim Yusuf showed, which I'm going to show in the next few slides. That's a real photomicrograph of a coronary artery from an Indian patient, which shows the lumen reduced to a small slit, a large lipid-laden plaque with some hemorrhages in it. What happens when you get a stroke, which is a thrombotic stroke? If an artery gets blocked by a thrombus, it's angiogram, and the artery supplies the heart muscle, which is being dead, it can cause microvascular complications in the eye. Diabetes probably is one of the commonest causes of blindness in the Western world. The patient can go into acute left ventricular failure causing pulmonary edema. Cerebral circulation may get an aneurysm which may burst. And the kidneys may become smaller, causing chronic renal failure. Stroke, MI, and renal failure are macrovascular complications, and the eye, feet are microvascular complications for diabetes. If I look at the post-discharge mortality of patients who come to the hospital ACS and look at them over 1 year, again the picture is frightening. About 14.8% patients get or die within a year. This mortality doubles within 1 year of discharge from the hospital. Unfortunately, we don't have the figures here in India, because we hardly have any registry of the patients who are discharged from the hospital where they are admitted with ACS or MI. What about the impact of risk factors on mortality? Patients who come to the hospital, the population can be divided distinctly on the basis of diabetes. And across every range, you see the mortality at least double in diabetics as compared to non-diabetics, in both ST elevation MI and non-ST elevation MI. If you look at the cholesterol, I'm sorry the cholesterol figures here in millimoles, which you may not recognize, but the one on the right side is a high cholesterol bar diagram, with a cholesterol of 6.7 and a high LDL of 4.9. But as the cholesterol starts coming down, so does the mortality comes down as well. With the lowest mortality in the left-hand column, with a cholesterol of 4.5, which is an average or below average cholesterol. If we change only one thing in the left-hand column, and the HDL becomes low to 4.8, the mortality becomes as high as the group with high cholesterol. And you may all know that the low HDL is the main problem among the Indian population. If we change one more thing to the left-hand column and make that population diabetic, the mortality is much, much higher. Please note that the cholesterol total in the left-hand column remains normal or even below normal, and the LDL is also average. But if you are diabetic and have a low HDL, your mortality actually is higher than high LDL group. So giving statins only to patients or Indian patients is not the only answer. We clearly have seen here that it is an unmet need. If I ask any one of you, you will tell me that your HDL is very low. And that really is a problem. If you combine that with type 2 diabetes, that really is focusing on a subgroup of people who are at high risk of vascular disease. Why do patients die of diabetes? Well, we know that the patients with diabetes live at least 15 years less than non-diabetic people. And the major cause of death in these patients is macrovascular complications and mostly ischemic heart disease. Of course, stroke and renal failure. The question is, by strictly controlling blood sugar or intensive blood glucose management to reduce HbA1c, do we prevent deaths in type 2 diabetics? The answer is no. What about people with type 2 diabetes with no previous history of ischemic heart disease? If you compare them with population of non-diabetic with previous MI, the risk of both the people for future MI is the same. And that's why type 2 diabetics are myocardial infarction equivalent. And that's why they should be treated with all the tablets which we give to the patient with heart attack without any previous history. That means all type 2 diabetics are treated with statin, ARBs, aspirin, plus minus clopidogrel. What about patients who come to hospital with MI but are not known to be diabetic? If you look at their blood sugar at admission, it becomes very clear that higher is your blood sugar, higher is your mortality in hospital. That brings us to the slide, which is one of the most important studies conducted in 52 countries to link or a quest to find one possible risk factor which is most closely related to the first myocardial infarction. And please note that all the risk factors in the study were modifiable. What we found that the most closely matched risk factor with the first MI is abdominal obesity. Of course, if you have abdominal obesity, then you will have low HDL, high triglycerides, a bit of hypertension, and maybe type 2 diabetes. That simply means that abdominal obesity actually represents a constellation of risk factors together. And we know that more number of risk factors you have as metabolic syndrome, higher is your mortality as shown on this slide. I've just said about this. If you see in the center of the slide of abdominal obesity, that brings together low HDL, high triglycerides, hypertension, type 2 diabetes. And if that person smokes, then the risk goes many times higher. What about abdominal obesity and link to mortality? It is very clear that the abdominal obesity is associated with increased risk of CV events, even the all-cause death. And that's very important. And not only cardiovascular deaths, but all-cause. In UK, as you move towards south, means London and south, you see more prosperous population. As you move towards north, you see more unskilled and financially challenged population. Unfortunately, in this population, you see the highest incidence of myocardial infarction. Unfortunately, in UK, it's 50% higher for people from Indian subcontinent than the rest of the population. I'm talking about mortality from CVD. Few years ago, I'm talking about 30, 40 years ago, any Indian patient coming to the hospital was hell-bent on finding out TB in that patient, as if every Indian patient has tuberculosis. There's some truth in it, but there's a high incidence of TB in people from Indian subcontinent in London. But now, if a patient comes to hospital with any symptoms, I mean any symptom, the first thing doctor and the hospital does is to find out if that patient has underlying coronary artery disease. So, being Indian means a very definitive risk factor for coronary artery disease in the world. This is a slide which shows the inter-heart study and the association of abdominal obesity with first myocardial infarction. What about the risk of mortality of individual risk factors like smoking, dyslipidemia, and hypertension? What really happens is if these risk factors are together, the risk becomes many times more than individual risk factors. And that was the problem is there in Indian patients probably, that they have undiagnosed many risk factors together. Hypertension. This slide clearly shows that as your diastolic blood pressure starts increasing above 80 millimeter diastole, your mortality actually goes on increasing. About 35 to 70% of adult population in Indian cities is hypertensive. In rural areas, 17 to 20%. And most of these patients are not diagnosed and not treated. What happens to people who live in rural areas, or let's say a bushman in Africa? Their blood pressure remains constant throughout their life, both systolic and diastolic. But the same bushman in Africa moves to the cities. Over the years, the systolic blood pressure starts going up. Epidemiologically, if you look at the difference between the systolic blood pressure and diastolic blood pressure, what we call pulse pressure, higher is this difference, higher is your all-cause mortality. It's very clear that the link is. If you go in London and go in the tube, as you're waiting for the tube on the platform, you immediately see written on the platform, mind the gap between the train and the platform. And that exactly we say for adult patients, mind the gap between systolic and diastolic blood pressure. Unfortunately, if you have a higher systolic blood pressure, treating those patients with normal ARBs or ACE inhibitors is going to increase mortality, because ACE inhibitors or ARBs do not reduce the systolic blood pressure. It will further reduce the diastolic blood pressure, and this gap pulse pressure will increase. So patients with systolic blood pressure is a completely different breed, and they require calcium channel blockers plus minus diuretics to control their systolic blood pressure. Many of these patients have secondary hyperaldosteronism, and adding just a small amount of spironolactone can work wonders in these patients. Rule of halves is very important to understand hypertension and epidemiology. 50% of all patients in the community in UK even are not diagnosed. Of these, 50% are not treated. Of these, 50% are not controlled. And overall, the controlled blood pressure patients are only 12.5% of the hypertensive population. This was the first study which showed the value of calcium channel blockers and ARBs over and above diuretics and beta blockers. Because traditionally, the treatment of hypertension consisted of beta blockers and diuretics. This was the first study which showed the mortality benefit if the patients are treated with calcium channel blockers and ARBs. And therefore, we clearly see the population of hypertensives as young or a little bit elderly. Young patients respond very well to ACE inhibitors or ARBs, but elderly population responds very well to calcium channel blocker plus minus diuretics. Unfortunately, we have removed the B from this now, which is a beta blocker. We never use beta blocker for treatment of hypertension anymore. The big problem as far as diabetes is concerned, about 17 to 20% of any population anywhere in the world has what we call pre-diabetes. These are the people who have impaired fasting glucose or impaired glucose tolerance, and they constitute a reservoir from which the people keep becoming type 2 diabetic. Another landmark trial called UKPDS trial, which was a combined United Kingdom and Swedish trial, which showed for the first time the importance of treating blood pressure in type 2 diabetes. Following this trial, it became very clear that one size does not fit all. So type 2 diabetics have different requirements for blood pressure. An ideal blood pressure for a type 2 diabetic is below 125 systolic and below 85 diastolic. Why? Because what normally is done for type 2 diabetes patients is what is your blood glucose, what is your HbA1c, why isn't it lower, intensive blood glucose control. Does that translate into mortality benefit? No. It will translate into microvascular complication prevention, but not mortality. What happened in the UKPDS trial was two groups were divided on the basis of intensive blood pressure control, and it clearly showed the lower graph a difference in the mortality of people whose blood pressure was better controlled. But the top graph shows there is no difference in the mortality statistically between intensive blood glucose control and not so intensive blood glucose control. Even if you look at the patients who come to hospital who are not type 2 diabetic and they come with an MI, even within the normal range of blood sugar, if we divide them into 4 quartiles, it becomes very clear that within a normal range of blood glucose, higher is your glucose level, higher is your mortality. So something is there in blood pressure, sugar, low HDL, abdominal obesity, which constitutes a phenotype, which is a high risk for premature mortality due to premature coronary artery disease. So what exactly is the risk of blood pressure and cardiovascular mortality? This mortality risk doubles with each 20 over 10 millimeters of mercury increase in BP. It's very clear. If the diabetic patient is hypertensive, he's got double jeopardy because the risk of death due to CVD is actually more than double if these two are together. So if we look at this together, South Asians are younger, they are prone to MI at an earlier age, and 25% of these MI patients are younger than 40. 33% are before the age of 45, and 50% before the age of 55. They are a sicker population, 4-fold higher risk of MI as compared to Europeans, 2-fold higher mortality after an MI compared to Europeans. I think this is very, very significant because the treatment equality and opportunity is absolutely perfect in UK. So that means the European patients and Indian patients are treated similarly, aggressively, with primary angioplasty, with all the secondary prevention, everything is free for everybody, but still the mortality in Indian patients is double as compared to Europeans. There's a 2-fold higher incidence of coronary artery disease. South Asians had an overall 10.7% incidence of coronary artery disease as compared to Europeans, which is about 5.4%. Unfortunately, 60% of the world disease burden is borne by Indians all over the world. 60% of all cardiac patients in the world are Indians. So excess burden of these conventional or metabolic risk factors, or is a shortage of protective behavioral factors, no exercise, no fruit, no vegetables, or there are emerging genetic factors, or this glucose insulin signaling is contributing to it, or maybe inflammation is contributing to it. We know that ischemic heart disease is an inflammatory disease. How do I know that? Well, I'm an interventional cardiologist. So patients come to me with an acute problem of MI, and I'm just scratching the surface. I'm just a plumber. I'm doing the plumbing for their coronary arteries, cleaning it and putting a stent in it. I'm not modifying the disease, am I? No, I'm not. You may say this, we treat secondary care, but I'm just scratching the surface. What I also see that up to 40% patients of MI or ACS after coronary angiogram do not have significant coronary artery disease. What I mean by that is they do not have a narrowing of the coronary artery which is 50% or more. That means I do not have any evidence to put any stent in them. But still they are having an myocardial infarction. There must be something. The reality is that if the coronary artery has a even small plaque and that plaque becomes inflamed, it can rupture, it can fissure, platelets can stick to it, cause a thrombus and cause myocardial infarction. So we have a problem now that we have an organ, heart, which is under attack from risk factors. Maybe a common factor is inflammation. We are not being able to completely protect the organ against risk factors by medication or prevention. So maybe we have to think innovatively here to see, can we address the inflammation to protect the organ against the attack by its risk factors, prevent it being damaged. We don't know the answer. It's the beginning at the moment that anti-inflammatory medication at a cellular and molecular level may be the answer. Unfortunately, this is the shape of things to come. With current epidemiological transition which is happening at a very fast pace in India, look at this man. This is what is happening at the moment in India. We have to address this. Think about it, realize it, unless you want to see the bigger picture getting further down at this age. Thank you.
Thank you, Dr. Parchure. Now the floor is open for questions. If you have any questions for Dr. Parchure?
Any questions? Sorry? We have not reached alpha blockers, but yes, alpha blockers are a good weapon in the armamentarium because alpha blockers can cause peripheral dilation, and maybe in combination with a calcium channel blocker and diuretic are a good combination for systolic hypertension, because systolic hypertension mainly is due to stiffness of the artery. And once the arteries are stiff, it's very difficult to control the blood pressure. And that's why we use alpha blockers in these patients in a combination with calcium channel blocker and diuretic. But yes, beta blockers, in fact, what we have seen now, that beta blockers can increase the mortality. It can cause erectile dysfunction. It can cause hypercholesterolemia, and it can cause depression. To an extent that all the media in Europe and UK have highlighted this issue, and if you are going to prescribe beta blockers in a very minute quantities for even your heart failure patient, which can improve the mortality in these patients, patients will complain that I don't want beta blocker because it may cause erectile dysfunction, it may cause high cholesterol, it may cause this, and it may cause that. So now beta blockers are only reserved for patients with a previous history of myocardial infarction or patients with heart failure.
58 years of a life expectancy, average life expectancy. 58 years of average life expectancy. I understand that you got that data from the UK,
Yes.
Indians in the UK.
Yes.
I'd like to ask the floor, I mean, is that the general impression out here, Indians in India, 58-year life, average life expectancy, does that match? In my mind, it doesn't because,
Yes, I'm not talking about general Indian population, I'm just talking about specifically Indian male GPs, doctors, family practitioners. Unfortunately, what has happened is their lifestyle has become like this. They're busy from morning till evening with their surgery, just sitting in the chair. They don't eat very well. When they go back home, all they do is eat and sit. And unfortunately, a large number of male Indian GPs, abdominal obesity and metabolic syndrome has become a real problem. I mean, What happens in UK is a unit in the population is about 220,000 population. And for each 220,000 population, we have a secondary care hospital, so many schools, so many GP surgeries, a market, a garden, all those things. And being a consultant in the hospital, your job is also to educate the GPs, do this all. So I know all my GPs because they are my referral base. They are referring patients to me. And unfortunately, large number of them have become my patients as well. So, and because being a small country of only 60 million people, and everything is on the register, you can pick up any registry. You want to have look at the registry of oncology, or we have a national database for heart attacks called MINAP, called Myocardial Infarction National Audit Program. So every patient who comes with a myocardial infarction in the hospital goes on this national registry. And it's a public registry, anybody can have a look. Now what has been done in UK is we have a largest biobank in the world, which is totally funded by the government, taxpayers' money. And we now have 750,000 samples in it. Means blood sample, urine sample, DNA sample, all patients CT scan of the brain, and echocardiogram. Now we are ready, it's completely automated. Everything is stored at minus 70 degrees, and any doctor can come for a study, and he'll be given the samples. So next stage is that you can have DNA access to say Indian population. They can give it to you. Thank you.